what if the medical symptom you're ignoring right now isn't caused by, a biological failure, but by your zip code?
Right, which is a wild concept to start with.
It really is, because usually when we think about healthcare, we tend to have this very, um, almost like a car mechanic mindset.
Oh, absolutely. The classic fix-it approach.
Exactly. You wait for a weird clanking noise, you take your body into the shop, the doctor points to a broken part, replaces it, and you're good to go. It's very binary, broken, fixed.
Well, and it's a comforting way to look at things, certainly. I mean, we prefer our problems to be isolated, visible, and, easily categorized into a neat little diagnosis.
Yeah, but human biology doesn't really work like that, does it?
Not at all. It fundamentally rejects that kind of simplicity. When we look at comprehensive women's health, we are forced to abandon the mechanic's garage entirely. We have to look at a massive, interconnected ecosystem.
Okay, let's unpack this, because whether you're prepping for your own checkup or just insanely curious about how modern medicine approaches women's health, we're moving way beyond basic biology today.
Way beyond it.
Our goal with this deep dive is to give you a shortcut to being a well-informed self-advocate in the healthcare system. So we are going to explore the astonishing mechanics of the female body, the hidden social barriers that actually dictate who gets care, and the holistic art of a true medical assessment.
And the foundational shift in modern clinical guidelines here is really moving away from just treating acute episodic illnesses.
Right, waiting for the car to break down.
Exactly. Instead of that, the focus is entirely on illness prevention. It's treating the patient as a biopsychosocial spiritual being.
That is a mouthful.
It is. But it basically just means optimizing health and anticipating risks long before they actually show up clinically.
But before we can really understand how women interact with that kind of holistic healthcare system, we have to establish the biological baseline, right?
We do.
Because the sheer engineering of the female reproductive system is just staggering. Take the uterus, for example.
It's a perfect example.
Yeah. It's not just a simple muscular sac. The muscular wall, which is the myometrium, it actually extends in three completely different directions.
Right. Longitudinal, transverse, and oblique.
Yeah. So why does a single organ need that intense level of architectural complexity?
Well, because it has to perform several totally contradictory functions, depending on the stage of life or even just the time of the month.
Okay, contradictory how?
So the outer longitudinal fibers are concentrated at the top, the fundus. That gives the uterus the downward pushing power required to expel a fetus during birth.
Okay, makes sense. Push down.
Right. But then you have the intercircular fibers near the bottom, which do the exact opposite.
Wait, they pull up?
They act more like a drawstring. They keep the cervix tightly closed during pregnancy, and they also prevent menstrual blood from flowing backward into the abdominal cavity.
Wow, okay. But the middle layer is the really crazy part.
So the middle layer is perhaps the most ingenious part of the whole system.
So, if I'm understanding this correctly, the middle muscle layer of the uterus is essentially like a self-tightening figure-8 knot that automatically acts as a built-in tourniquet after childbirth. That is an absolute engineering marvel.
What's fascinating here is that it is a literal survival mechanism built right into the tissue.
Right.
Those figure-8 fibers wrap directly around large blood vessels. The moment they contract, they ligate or tie off those vessels to control blood loss instantly.
That's incredible.
It really is. Without that specific multi-directional weave, childbirth would be catastrophically dangerous due to hemorrhage.
And that intricate engineering, it extends to the chemical choreography of the body too, right? Specifically the menstrual cycle.
Absolutely. It's a deeply complex system.
Because we always hear about this massive feedback loop between the endometrium, the hypothalamus, the pituitary gland, and the ovaries. But I really want to talk about prostaglandins.
Ah, yes. The usual suspects.
Yeah. Because usually prostaglandins are just cast as the villains behind terrible menstrual cramps. Like, are they just an evolutionary glitch that makes everyone miserable?
They certainly had a bad reputation for causing dysmenorrhea, painful cramps. Prostaglandins are basically oxygenated fatty acids classified as hormones.
Okay.
And menstrual blood is a really potent source of them. But calling them a glitch ignores their actual vital function. They are incredibly powerful modulators.
So they aren't just there to cause pain.
Not at all.
Huh.
Menstruation isn't just passive bleeding, right? It requires the active regression and sloughing off of the uterine lining. Prostaglandins are the chemical messengers literally commanding that tissue to detach and clear out.
But they also do things you wouldn't necessarily expect. Like the source mentioned that if prostaglandins are introduced into the vagina from ejaculated semen, they actually increase uterine motility,
Yes, exactly.
which means they literally assist in transporting sperm upward through the uterus.
They do. And on the flip side, they enhance uterine contractions to help initiate and maintain labor. So they are doing a lot of heavy lifting behind the scenes.
And this chemical choreography produces highly predictable mechanical responses that you can actually observe, right? Like if you know what to look for.
Yes, you absolutely can. Take Mittelschmerz, for instance.
Right, that localized lower abdominal pain.
Exactly. Some women feel it exactly during ovulation. It's not just a random cramp. It is the literal physical sensation of the follicle rupturing to release the egg.
Oh, wow. So you can actually feel the mechanism working.
You can. Or consider Spinnbarkeit, which is that stretchable, egg white-like cervical mucus that shows up right around ovulation.
What people usually just think is like a random discharge.
Right, but the body literally changes the viscosity of the mucus to create a microscopic ladder facilitating sperm transport. It's highly intentional.
And looking beyond just reproduction, the baseline mechanics of the physiological sexual response are completely fascinating too.
Oh, very much so.
If we look at the classic four-phase model by Masters and Johnson, excitement, plateau, orgasm, and resolution, what surprised me is the similarities. Like, despite the obvious anatomical differences, male and female physiological sexual responses are remarkably similar at a core level.
Yeah, physiologically, sexual response in both sexes boils down to two primary underlying mechanisms.
Okay, what are they?
First is vasocongestion. This is increased circulation and localized blood pooling in the pelvic organs, which causes the engorgement necessary for intercourse.
Right, and the second?
Second is myotonia, which is just increased muscular tension throughout the body that eventually results in the voluntary and involuntary rhythmic contractions of orgasm.
So the hardware looks different, but the fundamental operating system is incredibly similar.
That's a great way to put it, yes.
And for you listening, understanding your own baseline mechanics, whether it's how your uterus stops bleeding, what your cervical mucus is telling you, or how your nervous system responds to pleasure, it really demystifies those random pains and changes you might experience throughout the month.
It turns anxiety into empowerment, truly.
But here is the catch. As finely tuned as this biological machine is, it doesn't exist in a vacuum. If the machine is so perfect, why does it break down so often?
Well, because the biology is just the internal landscape. We have to look at the external hurdles, too, the environment that biology is forced to operate in.
Right. Which brings us to the social determinants of health. The current clinical consensus makes it very clear that your health isn't primarily decided by your genetics.
No, not at all.
It's decided by your zip code, your education level, your poverty level. I read that women actually use health services more often than men do across the board, but they have significantly more difficulty financing them.
If we connect this to the bigger picture, a lack of financial resources creates a whole cascade of biological consequences.
Like what?
Well, living in a lower-income zip code often means living in a food desert, facing higher environmental pollution, and experiencing chronic stress, all of which physically degrade that finely tuned biological machine we just talked about.
And that financial barrier is immediately compounded by cultural barriers, right?
Constantly.
Yeah.
Because healthcare isn't one size fits all. You could have a brilliant doctor and a perfectly treatable patient, but a lack of cross-cultural communication can entirely derail the care.
Right, and it's way beyond just language barriers. There are deep-seated differences in modesty.
Absolutely. In some cultures, privacy is valued so highly that women will avoid physical exams entirely unless it's an absolute life or death emergency.
Which is huge, because a well-meaning doctor might interpret a patient's refusal of a pelvic exam as them just being difficult.
Exactly. When in reality, it's a profound cultural boundary. Decision-making dynamics vary wildly as well. Some women rely entirely on their husbands or family elders to make all major medical decisions.
So if a provider tries to force, like, Western concepts of fierce medical individualism onto a patient who operates within a collective family structure,
The trust is broken immediately. It just doesn't work. But there's another massive barrier that frequently alienates patients before the exam even starts.
Oh, the handling of gender identity and sexual orientation.
Yes.
Let's define the terms clearly first, because clinical guidelines are actually very specific about this. Sex refers to biology and chromosomes, which includes intersex individuals.
Mhm.
Gender is a socially constructed identity, and sexual orientation is a completely separate component involving attraction and behavior. But a major hurdle is that the healthcare system often defaults to just assuming heterosexuality.
It does. When LGBTQIA plus individuals enter a clinic where heterosexuality is the unquestioned default, say, the intake forms don't have the right options, or the provider immediately asks what birth control a woman is using to prevent pregnancy, it creates immediate alienation.
They feel totally stigmatized.
Yeah, and they may hesitate to disclose their actual orientation or gender identity for fear of hostility or even a breach of confidentiality.
And here's where it gets really interesting.
Hmm.
There's a dangerous myth that if you aren't having heterosexual sex or if you've never had children, you're somehow immune to certain gynecological issues.
Oh, this is a very common, very dangerous misconception.
Right, like some providers and even patients might think, oh, I don't need an exam because I don't sleep with men. But the text actually points out that individuals who have never had children who are referred to clinically as nulliparous individuals are at a higher risk for breast, ovarian, or endometrial cancers. Why is that?
It fundamentally comes down to cellular turnover.
Okay, break that down.
Pregnancy and breastfeeding pause the menstrual cycle for long periods of time. That gives the reproductive system a break from the constant hormonal fluctuations of estrogen and progesterone.
Okay, so it's like a system rest.
Exactly. Nulliparous individuals, those who haven't had children, experience uninterrupted cycles for decades.
Wow.
More cycles mean more cellular division in the ovaries and endometrium. And every single time cells divide, there's a slightly higher statistical chance of a mutation that could lead to cancer.
Which means the feeling of being stigmatized or misunderstood by a doctor isn't just, an emotional inconvenience. It can literally be life-threatening.
It truly can. If alienation prevents someone from getting a routine screening, we completely miss the window for early detection on a cancer they are mathematically at higher risk for.
Right. Which really challenges you to think about how your own environment, your finances, or your identity shape your willingness to even book a doctor's appointment. Do you put it off because you feel unseen?
It's a vital question to ask yourself.
But let's say a patient manages to navigate past the financial barriers, the cultural stigma, and the alienation. They are finally sitting on the exam table. What are the actual threats the provider is looking for?
Well, it might surprise you.
Because if I'm walking into a well-woman exam, I just assume the doctor is primarily looking out for breast or cervical cancer. Is that where the highest risk actually is?
That is a very common misconception. When we look at the leading causes of death for women in the United States, reproductive cancers aren't at the top.
Wait, really? What is?
The #1 killer of women is heart disease.
Heart disease. That feels like it contradicts everything we're taught to worry about.
It does, largely because heart disease has historically been framed as a man's disease. And women's symptoms, like unusual fatigue, shortness of breath, or nausea, they often present differently than the classic, chest-clutching heart attack.
Wow, so they just get missed.
Exactly. That is why, woman care has to be a multi-system evaluation. It cannot just be waist-down medicine.
And a huge part of that multi-system evaluation is looking at lifestyle and substance risks, right? Like, the clinical data notes that smoking cuts a woman's lifespan by a staggering 14.5 years.
Yes. It's incredibly destructive.
How is it doing that much damage specifically to women's health?
Smoking systematically damages the endothelial lining, which are the inner walls of your blood vessels.
Okay.
This accelerates atherosclerosis, which ties right back to that #1 killer we just mentioned, heart disease. It also wreaks havoc on bone density and dramatically increases the risk of cervical cancer.
So that's why providers use the 5 A's for smoking cessation.
Right. Ask about tobacco use. Assess willingness to quit, advise quitting, assist with a plan, and arrange follow-up.
They also look at everyday substances, like caffeine. I noticed the guidelines suggest that consuming less than 200 milligrams of caffeine per day is likely safe during pregnancy.
That's correct.
Wait, really? Because you constantly hear that pregnant women should avoid caffeine entirely. Have we just been over-policing women's diets?
Historically, yes. There have been a tendency to default to total restriction out of an abundance of caution.
Which is frustrating.
It is. While massive amounts of caffeine can constrict blood vessels and reduce blood flow to the placenta, comprehensive studies show that moderate intake under that 200 milligram threshold, which is about 1 12-ounce cup of coffee, does not significantly increase the risk of miscarriage or preterm births.
So it's about evidence-based moderation, not total deprivation.
Precisely. But the assessment goes way beyond physical intake. It's deeply tied to mental health as well.
Right. Depression and anxiety are incredibly common, and they often exist comorbidly, meaning they travel together. But clinical protocols specifically highlight eating disorders, right? Like anorexia nervosa and bulimia.
They do, because eating disorders actually have the highest mortality rate of all mental illnesses due to the severe cardiovascular strain they cause.
That's terrifying. To screen for this, providers use something called the SDOF questionnaire. Is the SDOF questionnaire basically used as a vital sign check for mental health, just like a blood pressure cuff is used for physical health?
That is a highly accurate analogy. Patients with eating disorders are often deeply secretive or in denial, so just asking, "Do you have an eating disorder?" rarely works.
Right, they'll just say no.
Exactly. The SDOF questionnaire bypasses that denial by asking about behaviors rather than diagnoses.
Okay, so what are the actual questions?
It's an acronym. S is for sick. Do you make yourself sick because you feel too full? C is for control. Do you worry you've lost control over how much you eat?
Okay, and the O.
O is for 1 stone. Have you lost more than 1 stone, which is about 14 pounds, in a 3-month period?
Right, because it's a British tool originally.
Yes. F is for fat. Do you think you are fat even when others say you are thin? And the final F is food. Does food dominate your life? And what's the threshold for concern there?
A score of 2 or more acts as an immediate red flag for deeper intervention.
This raises an important question, though. Why are we seeing such high rates of these mental health and lifestyle-related illnesses? The guidelines spend a huge amount of time on stress.
They do, because the modern lifestyle is basically a pressure cooker of multiple roles, financial burdens, and caregiving duties.
So what is actually happening inside the body when we're constantly stressed like that?
From a biological standpoint, excessive ongoing stress triggers a severe physiological cascade. Your brain perceives that modern pressure cooker as an immediate, literal physical threat, so it releases adrenaline and cortisol.
Basically the fight or flight response.
Exactly. This causes a rapid heart rate and elevated blood pressure. Crucially, the body shunts blood and energy away from non-essential systems, like your digestion and your immune system, to prepare for that fight or flight.
Oh, wow. So your body just stops prioritizing basic maintenance. Yes. And over time, that constant diversion of resources creates actual clinical illnesses, like irritable bowel syndrome, autoimmune flare-ups, and cardiovascular disease.
And unfortunately, sometimes the threat isn't just workplace stress, right? It's physical danger. The medical setting is often the only safe place a woman can admit to intimate partner violence, or IPV.
It is often the one closed-door conversation they get.
But how does a doctor even bring that up without putting the patient in more danger, especially if, like, the abuser is literally waiting in the lobby?
This is why universal screening is so critical. Instead of only asking women who, quote-unquote, look like they might be abused, providers are trained to ask every single patient in private.
So they normalize it.
Exactly. They frame it as routine. Because violence is so common in many people's lives, I ask all my patients about it.
That's really smart. Providers are also trained to spot signs of extreme trauma, right? Like female genital mutilation or FGM and human trafficking.
Yes. FGM involves the non-therapeutic removal of part or all of the female external genitalia.
And that's still happening.
It's practiced globally, and providers in North America are actually seeing it much more frequently. It causes chronic pain, severe infections, and massive complications during childbirth. It is internationally recognized as a human rights violation.
And what about human trafficking?
Similarly, providers are trained to identify signs where patients might be forced into labor or sex work.
What kind of red flags are they looking for?
They look for things like a patient who isn't allowed to speak for themselves or someone who lacks control over their own identification documents.
It's really heavy. And it forces us to slow down and realize that a well-woman visit is profoundly comprehensive. It's a holistic check of your mental, emotional, and environmental safety.
It absolutely is.
So how does a healthcare provider actually conduct this incredibly vulnerable assessment without completely overwhelming the patient?
Well, the structure of the visit is highly intentional. It always starts with the interview, which really sets the tone.
Okay.
Importantly, the interview should be conducted while the patient is fully closed to maintain a balance of power, dignity, and comfort.
Oh, that makes so much sense. Nobody feels empowered sitting in a paper gown.
Right. And the provider uses specific communication tools to build trust. For instance, reflection, which is simply repeating a phrase the patient just said to encourage them to elaborate without interrogating them.
Just echoing them back.
Yes,
Uh,
or clarification, asking them exactly what they mean when they describe a pain as, say, sharp.
and then comes the physical and pelvic exam. For a lot of women, just the thought of the standard lithotomy position lying on your back completely exposed with your feet in metal stirrups, it's physically uncomfortable or even emotionally triggering.
Very much so.
But the current standard of care emphasizes that the patient should remain in control. The lithotomy isn't the only option, is it?
Not at all. A skilled provider adapts to the patient. For women with physical disabilities, severe arthritis, or even just high anxiety, they can use an M-shaped position where the feet rest on the table.
Okay, so no stirrups.
Right. Or they can use a V-shaped position, or even a side-lying position. The goal is to obtain a thorough clinical assessment, not to enforce a rigid traditional posture.
And the exam itself is a prime opportunity for preventative teaching, right? The pelvic exam isn't just about the provider looking, it's about teaching the patient to look.
Yes, that educational component is huge.
They teach vulvar self-examination, or VSE, so women can spot precancerous changes early. They also teach Kegel exercises. And the clinical description of how to actually do a Kegel in the source material is great.
It's very practical.
It is. The guide literally describes it as pretending you're trying to stop yourself from passing gas in a crowded room or stopping the flow of urine midstream, which is a funny way to phrase it, but it immediately makes you realize exactly which hidden muscles you're supposed to be using.
It's a highly effective visualization. You contract those pelvic floor muscles without clenching your abdomen or thighs, and you hold it for 10 seconds.
And that actually helps.
Oh, immensely. It strengthens the entire muscular sling supporting the bladder, uterus, and rectum, which helps prevent incontinence later in life. It's a perfect example of giving the patient the tools for self-management.
So what does this all mean? It sounds like a successful exam is less about the doctor finding something wrong in the moment and much more about the doctor acting as a coach to teach the patient how to interpret and manage their own body.
That is the absolute essence of modern care. The ultimate goal of the assessment is anticipatory guidance.
Anticipatory guidance, I like that.
The provider synthesizes all this data, your genetics, your stress, your zip code, and applies screening guidelines to map out a strategy for longevity.
Like giving you a roadmap.
Exactly. They might advise a Pap test starting at age 21 to screen for cervical cancer, mammograms around 40, and a colonoscopy at 50. It's preparing the patient for the next stage of life.
Which should empower you, the listener, to advocate for yourself in the exam room. If you're dreading your next appointment because you always feel rushed or unheard, knowing that you have the right to ask for an M-shaped position instead of the stirrups completely changes the power dynamic in that room.
It puts you back in the driver's seat.
Right. You have the right to ask for a mirror during a pelvic exam so you can see what the doctor sees. You have the right to be treated as a collaborative partner in your care.
The goal is to move from being a passive recipient of medical commands to an active manager of your own health portfolio.
So we've journeyed from the mechanical marvels of the uterus acting as a self-tying tourniquet through the deeply ingrained social and cultural barriers that dictate healthcare access, all the way to the empowering, holistic art of the medical assessment. It really is a vast, beautiful ecosystem.
It is. And it leaves us with a lingering thought. We've learned today that social determinants like your job, your stress levels, and your physical environment dictate your health just as much as your genetics do. So looking at your life right now, how might your everyday, non-medical environment be actively writing your future medical history without you even realizing it?
That is a profound question worth carrying with you. Next time you schedule a checkup, remember, you aren't a car going to the mechanic. You are a complex, interconnected ecosystem, and you deserve a provider who treats the whole environment. Thanks for joining us on this deep dive into the underlying forces of women's health. Keep learning, keep asking questions, and we'll see you next time.